back to our webinar series. Our webinar today will discuss fertility concerns for the brain tumor survivor. My name is Jillian Demas, Senior Program Manager here at the American Brain Tumor Association. I'm delighted to introduce our speaker today, Dr. Lisa Culp. Dr. Culp is Assistant Professor of Gynecology and Obstetrics at Johns Hopkins University. Her research interests fertility preservation methods for women who are facing potentially sterilizing cancer treatment. She is a diplomat, National Board of Medical Examiners, and a diplomat, American Board of Obstetrics and Gynecology. Thank you so much for joining us, Dr. Culp. You may now begin your presentation.
Well, thank you for inviting me. As Jillian said, this is a subject that is of great interest to me. I would like to talk about fertility concerns for brain tumor survivors. We are going to talk about the effects of radiation therapy that impact the hypothalamus and pituitary area of the brain. We're going to talk about the effects of chemotherapy. My area is primarily focused on women, but I will try to touch on how this relates to men, and much of what I say is generalizable to men. So what we know is that cancer chemotherapy and craniospinal irradiation are toxic to the gonads, meaning the ovaries and the testes, and they can also cause damage to areas of the brain that regulate the reproductive system. Cancer treatments were originally designed when cancer was a nearly always fatal disease, and the goal was cure. The secondary goal was to avoid overlapping acute toxicities, meaning if one drug was particularly bad at suppressing the bone marrow, then they would try to combine that with a drug that had a side effect in a different category. Now survival rates are such that planning for the future is appropriate, and long-term toxicities are getting more attention. In fact, the American Society of Clinical Oncologists has now said that as part of the education and informed consent process before cancer treatment, oncologists should discuss the possibility of infertility with their patients and be prepared to discuss or refer those patients to people who can help them with those issues. Sperm and embryo cryopreservation are considered standard practice that should be available to anyone approaching cancer treatment. What we know is that the reproductive control systems are located primarily in the hypothalamus, which is located at the base of the brain, kind of between your eyes and above your nose, and in the pituitary, which is just below the hypothalamus and just above the roof of the mouth. Because it's right smack in the center of the skull, basically, radiation that treats most any tumor in the brain is going to impact the hypothalamus and pituitary areas. This is kind of a schematic that shows why this is important. The hypothalamus, the part of the base of the brain, releases for reproductive considerations GnRH. This hormone travels to the pituitary, which is just below the hypothalamus, a space of maybe only a ½ an inch to an inch. And in response, the pituitary releases LH and FSH. These two hormones act at the level of the gonads, the ovaries and the testes, to make hormones, steroid hormones, that feed back to the hypothalamus, and they communicate that way. And then the hypothalamus knows what the gonads are doing, and the regulation hormones change in response to the message it gets back from the gonads. When this part of the brain is affected by radiation therapy, the regulation of the gonads can be thrown off. High doses of radiation to the brain can damage this area. I've put kind of a list here of common causes for radiation to this area of the brain in order of decreasing doses of radiation. Nasopharyngeal tumors, meaning tumors that are in the nose or the pharynx, that area that is behind the nose and above the roof of the mouth, are right adjacent to this primary regulatory area. These tumors often require high doses of radiation and affect the area in many cases. Pituitary gland tumors, of course, when they are radiated, the pituitary gland is damaged. Brain tumors in general often require radiation that is enough to affect this part of the brain, although the dose is usually less than what we see for nasopharyngeal tumors or pituitary gland tumors. Patients with leukemia sometimes receive prophylactic treatment of the brain. This is a treatment that was common in the past and is less common now. Whole body irradiation usually occurs in preparation for a bone marrow transplant. It is less likely to be a dose that's high enough to damage the regulatory regions in the brain. What we know is that people who've had previous radiation in an area that includes this regulatory system, about 74% will have some amount of thyroid dysfunction. The thyroid is also regulated in that part of the brain. About 2/3 will have dysfunction of the ovaries or testicles. About 52% will have an elevated prolactin hormone. That is a hormone that regulates milk production, and when it's elevated inappropriately, that can interfere with the function of the ovaries or the testicles. And a smaller number will have adrenal dysfunction. So the part of the pituitary that governs the thyroid is the most sensitive. The second most sensitive is the part that regulates the gonads. If these systems fail, you can have hypothyroidism, which is underactive thyroid. If the gonads are not working and the treatment was done in a pre-pubertal age range, you can fail to go through puberty. People can be diagnosed with growth hormone deficiency and failure to grow. And they can have symptoms of low testosterone or low estrogen when the ovary and the testes are not being stimulated. The good news is we can substitute for those missing hormones for general well-being. People who have symptoms of low estrogen or low testosterone can be treated with estrogen and testosterone and feel well, and it also is good for their general health. Those who are having growth deficiency as a result of this problem can be treated with growth hormone, and thyroid hormone replacement is also very easy, very straightforward, and very commonly done. But what about having a baby? I think we should first address, is it safe to have a baby? Can I still have a baby? And what can I do before treatment to maximize my chances of being able to have a baby after treatment? Is it safe to have a baby after cancer treatment? In general, the answer to this question is yes. There are some tumors that are estrogen dependent. We know the estrogen level goes very high in pregnancy, so those can be a separate consideration, but those are tumors like breast cancer and not the kind of brain tumors that we're talking about today. What we know from a fair amount of data at this point is that the offspring of people who have been treated for cancer are usually healthy. This, of course, assumes that there's been a certain amount of time passing after the treatment with chemotherapy or radiation prior to the pregnancy. But assuming a certain amount of time, let's say a couple of years has gone by, then the previous cancer treatment does not affect the chance of a miscarriage, does not affect fetal growth, the risk of prematurity, or the risk of birth defects in the baby. If a person is ready to try to have a baby after having high dose of radiation to the brain, all of the regulatory hormones that are present can be replaced. Sperm production and ovulation can be supported so that natural conception can occur. These treatments are expensive. They have a higher risk of multiple pregnancy, but in general, the effects of radiation therapy alone are relatively easy to manage. This will then review what we are able to replace. This hormone, GnRH, is available in a bottle. Used to be available in this country, not so widely available anymore. But we do have LH and FSH in a bottle that we can provide and administer to make the testes function normally to make sperm and make the ovaries function normally to ovulate and release an egg. Chemotherapy is another problem, a separate problem. Those who are exposed to chemotherapy can have damage to the testicles and the ovaries that cannot be overcome. The effect of chemotherapy is age, dose, and agent specific, meaning the younger you are, the more likely you are to recover from the effects of chemotherapy. The dose of the agent is important in terms of how badly it affects the gonads, and the agent is specific. We know that some agents like cyclophosphamide or other agents that are considered alkylating agents are the ones that are particularly toxic to the sperm and eggs. These medications can result in loss of eggs and sperm production. Men continue to make sperm all their life, so if the sperm production is not completely wiped out, the sperm production may recover. In women, on the other hand, women have all the eggs they're ever going to have when they're born, and loss of eggs eggs that are lost cannot be replaced. So let's talk for a minute about the effect of chemotherapy in men. The germinal epithelium of the testis is more affected than the Leydig cells. What that translates into, most treatments will result in impaired sperm production. The germinal epithelium is damaged more so than the hormone-producing tissue. So a man can have impaired sperm production without any dramatic effects on his testosterone production. So a man can feel healthy and have perfectly normal sexual function even if he no longer makes any sperm. If a man is facing a treatment that is likely to damage his sperm production, we can freeze sperm for him prior to treatment. Surprisingly, when we started offering sperm freezing to men who were facing chemotherapy, we found that many men had abnormally low sperm counts when they were when they were diagnosed with cancer. Some of these men, of course, were quite ill when they were diagnosed, but some were quite asymptomatic, and it was surprising that their sperm count was low. We also know that freezing sperm leads to about 50% loss of the ability of the sperm to swim, and about 50% loss of viability, meaning about 50% of the sperm do not survive the freezing process. However, there are ways that with infertility treatment that we can work with even very low numbers of sperm, so it's generally worth freezing sperm prior to treatment. The cost and the time for sperm freezing is not prohibitive. It costs about $400 to store a sperm specimen in most labs. There is a Sharing Hope program that I'll talk about a little bit more later that provides a service at about half price. Most centers have an annual storage fee. We do ask you to decide about what happens to your sperm if you do not survive. And ideally, if a man was able to give a sperm specimen every other day for about 3 times, each of those specimens would be divided up into 2 or 3 vials. So that might leave him with 8 or 10 vials of sperm, which is a lot to work with when the time comes to try to have a baby. For boys who are younger than puberty, luckily they are more resistant to the effects of chemo and radiation because boys do not produce sperm until they reach puberty. There is some experimental work being done in which testicular biopsies are being taken from these prepubertal boys. The testicular tissue is frozen and saved with the idea that it can somehow be replaced into the testicle, or perhaps sperm can be developed in a laboratory setting in the future to produce sperm for this young man. Currently, there is no technology that is available to use this sperm, this tissue at this point. We don't know the best way to freeze it. We don't know that the tissue will survive. In general, we are very uncertain about how to use this frozen tissue. It's considered quite experimental, but is sometimes being offered. Now let's turn for a minute to the effects of chemotherapy in women. Again, the effects are age, dose, and agent dependent. Women have all the eggs they're ever going to have when they're born. Therefore, if a chemotherapy destroys 90% of a woman's eggs, 90% of the eggs that she has when she's 15 will still leave her with many more eggs than if she loses 90% of her eggs when she's 40. So younger women are more resistant to the effects of chemo. Cyclophosphamide and other agents that are called alkylating agents are considered to be the worst. We don't really know precisely with different chemotherapies which are safe and which are not. In general, we think they all cause some damage. The part of the reason that we don't really know is the combinations that are used change regularly, and just when we feel like we have a handle on one combination or another, then the treatment plans change. In general, I tell people that there's about a 50% chance that all of their eggs will be destroyed as a result of their chemotherapy. Some women, young women or girls, have been treated in childhood, and clearly they still have some eggs left because many of them will go through puberty and start periods which indicates that they are ovulating and still have eggs left. However, if you study these women closely, you can recognize that the ovaries are small and the number of antral follicles, the little cysts in the ovary where eggs are found, are less than women who have not had cancer treatment. These findings indicate that there has been some loss of eggs, although obviously not all of the eggs are lost. So what can we do for women to try to preserve their fertility prior to treatment? Embryo cryopreservation is considered a standard technique. It's been available for about 30 years in vitro fertilization programs. It's not perfect, but we have the details of that process pretty well worked out and understand how to do it and can give you a pretty good idea of what to expect. Oocyte cryopreservation is basically egg cryopreservation. The difference between an egg and an embryo is that the egg has not been fertilized. An embryo is a fertilized egg. If neither of those is appropriate, sometimes we would actually freeze a piece of the ovary with all the microscopic eggs present in that piece of ovary. Let's talk for a second about embryo cryopreservation. It's a well-established technique. You do have to go through basically an in vitro fertilization cycle that can take 2 to 3 weeks, so we have to have a window of opportunity prior to treatment. It requires a partner because an embryo is a fertilized egg. Approximately 80% of embryos will survive the freezing process for use later. And at this point, we are having about a 40 to 60% chance that a pregnancy will occur every time 2 of these frozen and thawed embryos are put back in the uterus later after treatment has been completed. If we don't have a male partner and we have to freeze eggs that are unfertilized, this is a newer procedure. It has been until recently considered experimental. At this point, they're starting to say it's not experimental, but it still has a much lower success rate. It also requires that you basically go through an in vitro fertilization cycle, which can take 2 to 3 weeks. And we quote about a 3% per egg chance of success, meaning a baby later when you come back for the frozen eggs. To try to understand the difference between embryos and egg or oocyte freezing, let's say, for example, a woman who has 15 eggs obtained at the in vitro fertilization procedure. If you were able to fertilize the 15 eggs, maybe you would get 10 to 12 that would fertilize properly and continue to develop properly and be available for freezing. If you had 10 to 12 embryos, that would be 5 or 6 times that you could transfer 2 embryos each time. Each time you transfer 2, there's a 40 to 60% chance of pregnancy. So if a woman was able to get 15 eggs, we would feel very confident that after 5 or 6 embryos, with almost a 50-50 chance every time she tries to get pregnant, we would feel confident that she would have a baby or 2 out of that batch of embryos. If we were not able to fertilize the eggs and we have just frozen eggs, again, out of the 15 eggs that were recovered, maybe 12 would be mature, healthy, viable eggs. And at 3% per egg, we say about a 36% chance that we would get 1 baby out of that whole batch of eggs. So being able to fertilize the eggs and create embryos has a much higher success rate. But if there is no male partner, freezing eggs without fertilizing them is a process that is under development. It has a steadily improving success rate, and the people with the best success rate are young women, which are usually our candidates for fertility preservation. If neither egg freezing nor embryo freezing is appropriate, or there's not enough time, we do sometimes freeze a piece of the ovary. The ovary has many eggs in it that are tiny and microscopic, and hidden in the cortex, the outside covering of the ovary. This clearly is experimental. It can be done on very short notice. It doesn't need to delay any cancer treatment. Insurance, for the most part, is not covering it at this point. And there is some discussion in our field about whether it's best to freeze just a piece of the ovarian cortex, which is the covering over the ovary, versus freezing the entire ovary. So it's possible you'll hear discussion about one or the other if this option is offered to you. If you have a piece of ovary frozen and you're ready to have a baby, what will we do with the piece of ovarian tissue? At this point, we are not able to get eggs from the tissue in a laboratory setting. In vitro means a laboratory setting, and the eggs that are in that piece of ovary are not mature, so they cannot be fertilized. They need to be matured before they can be fertilized, and as yet that is not possible. There's a lot of work being done in this area, but as yet we are a long way from creating a baby from a piece of ovary in a laboratory setting. Xenotransplant means taking that piece of ovary and putting it into an animal model where it can grow. This is not advised. It's done in some experimental settings more to understand the best techniques than to get eggs that would actually be used. Autologous transplant means you take that piece of ovary and put it back into the woman from whom it came. This is possible. This is being done. There are approximately 18 babies in the world at this point born from pieces of ovarian tissue that were frozen and then put back into the woman at a later date. That may not sound like very much, but it's clearly a procedure and a technique that is doable and is getting a lot of attention and is something that will improve with time. If you have the piece of ovary and you're ready to put it back, there are several things we think about. What is the best timing, because how long will that piece of ovary last? What is the best place to transplant that piece of ovary? And is there a risk of giving the cancer back to the woman by putting the piece of ovary back? The transplant seemed to last 2 to 3 years, maybe a little bit longer. So it's not something we would put back just to provide estrogen, but we would put it back when the woman is ready to actively be trying to conceive so that she can make the most of the 2 or 3 years that the transplant survives. The best place to transplant is also under discussion. For a while, pieces of ovary were being transplanted into the fatty tissue in the arm or on the abdominal, under the abdominal skin. These places were convenient for trying to get the eggs out after they matured, but nobody has been able to create a baby yet from an egg that was obtained from the fatty tissue. It looks like, for some reason that we don't understand yet, the piece of ovary has to be transplanted back into the pelvis to work. Maybe it has to do with temperature stability, maybe it has to do with pressure, we're not sure, but it looks at this point like it has to be transplanted back into the abdomen to have a chance of working. The bigger concern is, might we give the person cancer back by putting their piece of ovary back? What we know from reviewing the risk of malignancy after organ transplant, sometimes people who are donors for example, a kidney transplant or a liver transplant or a heart transplant are found after the fact to have a small cancer that they were unaware of. These cancers can often be transmitted with the organ that is transplanted, and the cancer often shows up in what we call an atypical site. One man who was a heart donor was found after the fact to have a very small cancer of his prostate, and the heart that was transplanted developed cancer that looked like prostate cancer. It is possible for lung cancer to be transported in a liver transplant. One organ donor had had a melanoma 16 years previously, and when she died in an accident, 2 of her kidneys and her liver were transplanted, and each of the recipients developed melanoma. So how cancer can be transported in organs is not well understood. When we look at organ transplants, brain tumors, CNS tumors, are considered one of the highest risk for transporting malignancies. And so we're very cautious about the idea of using a piece of ovarian tissue or saving a piece of ovarian tissue and then putting it back into the woman at a later date, with the concern being that we would give her her cancer back. I want to touch for a minute on the Sharing Hope program. This is part of the Livestrong Foundation. Many fertility centers participate. The IVF cycles that I have mentioned as a way of preserving embryos and eggs are not inexpensive. The total cost is often around $15,000. About a third of that cost, or maybe $5,000, is the medications. If you participate with the Sharing Hope program, the medications are provided for free, and the fertility centers that participate agree to hold the total cost down to something less than $5,000. This makes it manageable for many people who obviously haven't had time to save up for an IVF cycle. In order to qualify for the Sharing Hope program, there are income restrictions, which I believe are something like you have to make less than $150,000 a year. You have to have had no previous cancer treatment. Your insurance has to refuse to cover it, and you have to be having a treatment that is at risk for causing infertility. Most cancer patients qualify easily, and the Sharing Hope program has been very generous with providing the medications and making it possible for patients to start the cycles right away and not interfere at all with their cancer treatment. For patients who have already completed treatment and have not done embryo or oocyte cryopreservation, when it's time to have a baby, a thorough evaluation for infertility is appropriate. As I indicated earlier, thyroid dysfunction is very common after radiation treatment to the brain, and a low thyroid function is a very common cause for infertility and is extremely treatable. Likewise, the prolactin is often inappropriately elevated after radiation treatment to the brain. Prolactin is the hormone that makes you make milk. It should not be elevated except when you're pregnant or breastfeeding. And there are easily obtained medicines that can lower the prolactin, and sometimes that can result in normal ovulation. A woman or a man who has had radiation or chemotherapy for brain cancer should have a thorough evaluation, just like any other couple. We evaluate whether or not the woman is ovulating, what her hormone status is, whether her fallopian tubes are open, and what the man's sperm count is. Women who fail to ovulate may be manageable with injectable fertility drugs. If you will recall my earlier schematic, the FSH and LH hormones that are disrupted by radiation treatment are available. They are injectable medications, but they are available and can be administered and result in normal ovarian function. If the man still makes sperm, but the sperm count is quite low, this can often be managed by artificial insemination with his sperm into his partner, or if the sperm count is quite low, that can be managed by in vitro fertilization. Especially sometimes we do what's called ICSI, I-C-S-I, intracytoplasmic sperm injection. In that procedure, the female partner undergoes an IVF procedure to get many eggs, and each egg has a single sperm injected into it to maximize the chance of fertilization, even with very low sperm counts. Women who have had chemotherapy will almost always be expected to have what we call decreased ovarian reserve. And what that is another name for decreased number of eggs remaining in the ovaries. This is to be expected. The diagnosis should not be a surprise, and it should not be a reason not to proceed with infertility treatment. For those who have no sperm, men who have no sperm, pregnancy is certainly possible if the female partner is inseminated by sperm from a sperm donor. There are several large sperm banks in the country. I've just put the website address for one of them. I'm not promoting this one, but it's a very nice representative sperm bank that you can look at their website and get a good idea of what using a sperm donor is all about. For women who have no eggs left and have been diagnosed with ovarian failure, pregnancy is possible using donated eggs. The eggs can be fertilized with the husband's sperm and placed back into the woman's uterus, where she can be expected to carry it normally. This process is expensive, in the range of $25,000 per try. It is an IVF cycle that the egg donor goes through, but it has an extremely high success rate, perhaps 60 or 70% chance of success with any two embryos that are transferred. It is also possible in some cases to adopt embryos. This is a relatively new process, but is gaining in popularity. There is an organization called the National Embryo Donation Center that is centered, I believe, in Tennessee, that is a national clearinghouse for embryos that have been donated. And if you qualify for this procedure, the embryo is thawed and placed back into the woman's uterus, and she can be expected to carry it normally. The Snowflake organization, I believe, is based in California and is likewise a clearinghouse for embryos that have been donated. The total cost is also going to be in the range of $20,000 for embryo adoption. And if none of those is feasible or desirable, more typical adoption is certainly a way to build a family. I will warn you that a normal social services or Catholic charities type of adoption can be a problem in a couple where one member has a history of cancer. There's always a long waiting list for babies, and the waiting lists tend to be whittled down by declining people who are older, people who have medical conditions, people who have a history of serious medical conditions. So it may or may not be possible to adopt through a social services type agency. However, private adoption does not have the same limitations, and it is often possible to adopt that way. In conclusion, let me say that treatment of brain tumors has the potential to impact reproduction. Radiation to the brain can have multiple effects, but these can generally be overcome with medications that are in standard use. Systemic chemotherapy can impact the sperm or egg production, and this is a bigger problem. Depending on the reproductive challenges that are detected, treatment options do exist, and a reproductive endocrinologist or a urologist who specializes in infertility should be able to help you navigate through your treatment options. Thank you, and I'd be happy to take questions.
Thank you so much. We were enthralled here, so I would imagine that the other people listening are too. That was amazing. We have some questions that have been posted beforehand and live as we've been talking, so I will give those to you. Someone's asking if they're at risk more than average to have a child with complications after having a brain tumor and being on Temodar.
The question is a little bit hard to answer, and primarily because, of course, 20 years ago, people didn't survive cancer for the most part, and so they didn't have babies afterwards. So what we have is relatively short-term information, but our best information now is that chemotherapy, once a certain amount of time has passed, does not make you high risk, does not make the pregnancy itself high risk as long as the chemotherapy is long past and you have proper hormonal treatment to support the pregnancy.
Thanks. What about brain MRIs and the gamma knife? Are those considered things that might have possible complications due to them?
The brain MRI is perfectly safe, even if it would be necessary during pregnancy to follow up on some symptoms that have developed and caused a concern about recurrence or something. The MRI does not involve radiation, so it's felt to be safe in pregnancy. Now, sometimes when they do an MRI, they like to use a contrast agent. We prefer that they not use that in pregnancy, but it's always a situation where the benefits are weighed against the risks. And the MRI itself is safe. Maybe the contrast should not be used. Now, the gamma knife, what the gamma knife basically is very high dose focused radiation. The good news about the gamma knife is it probably is more likely to spare the hypothalamic and pituitary areas if they're not involved with the tumor, because the gamma knife is more precise. However, it's very high dose of radiation. It's frequently used for pituitary tumors. So gamma knife treatment of the pituitary or in the area of the hypothalamus would actually be higher risk of damage to those areas because of how high the dose is.
Great. Someone's asking you to explain the connection between hypothyroidism and brain tumors and fertility. In this case, they're asking about a benign brain tumor, but if you have information about both, that would be great.
Well, the hypothyroidism is a result of radiation to the hypothalamus or the pituitary area, and I'm not sure that would happen from a benign tumor. There are benign tumors, for example, prolactin secreting tumors that damage the pituitary, the craniopharyngiomas that damage the pituitary. So those would be benign tumors that can damage the pituitary and result in hypothyroidism. Hypothyroidism, the thyroid hormone is a kind of a general thermostat for the body. It kind of regulates a little bit of everything, including the reproductive system. So women who have low thyroid function usually do not ovulate. If they do ovulate, they're at higher risk of miscarriage. But hypothyroidism is very easy to treat with just a small pill taken once a day that's very easy to tolerate. So if it's detected, the hypothyroidism is detected, it should be very treatable.
Thank you. Someone is mentioning that they went through chemoradiation and self-transplant at the age of 3. Is there anything she can do today to increase the chances of being fertile in the future?
Well, the important thing would just be to know if she has gone through puberty normally, because in order, I maybe didn't make this point clearly. I did try to make the point with men that they can have perfectly normal hormonal function, go through puberty, and have normal sexual function even though they make no sperm. That's not true for women. If women don't have any eggs left, they don't make any estrogen. If they don't make estrogen, they will not have a normal puberty. They won't have breast development. They won't have pubic hair. They won't have a growth spurt. They won't start their periods. If they have those things, on the other hand, if they have breast development, if they start their periods, then they have eggs and they are ovulating. What we know is that women who were treated in childhood are at risk of premature menopause. The best thing they can do is try to have their children as early as is feasible and reasonable for their own personal situation. It would be appropriate for them to check in with a gynecologist early and have their ovarian reserve assessed, knowing in advance that they're likely to be told they have decreased ovarian reserve and they should not panic, but that will hopefully give them some idea of how long their ovaries are going to continue to function and what their chances of having a baby in 1 year or 5 years or 10 years, depending on how old they are.
Great. And there's another one kind of piggybacking off of that, they had a rare tumor and do not know actually if the treatment sterilized them or would cause birth defects. So what would you recommend for someone who's in this situation, starting to think about a family in a few years, how do they go up, finding that they're infertile or not, and what deficits they could possibly, be expecting?
Well, again, a woman who goes back to having normal periods or goes through puberty and develops normal periods after treatment is ovulating and is potentially fertile. If she doesn't want to get pregnant, she needs to be aware of that and using birth control. So the best kind of overall general indicator is, are you having normal periods? Normal periods usually mean you're ovulating and that you are potentially fertile. Now, the use of a new medication, this is our bugaboo with all of this, is trying to know from 1 year to the next about this new medication versus the old one and the old one in combination with the new one. And our general approach is to say all medications are likely to damage some eggs, and how many relates to how old you are, exactly what the agent is. It's impossible to know with any given medication, but the best general indicator is, are you having periods?
Great. I think that helped clarify for the few people who are asking that. Right now we don't show any questions, so if anyone out there has another question, wants to type it in, we can wait a few moments, and we'll see if anything pops up. I would like people to know that a transcript of this webinar will be at our website as well as the webinar. So if someone is interested in reading the transcript or having that available, we make sure that we have that for people who have a hearing deficit or people that just want to read your presentations. That's nice to offer. So we did get a couple more that came in, so we do have some time. How long after chemo, TMNR treatment, is it acceptable to start having a family?
That is something that we kind of negotiate with the oncologist in every situation. General rule of thumb is at least 2 years. There is no hard and fast answer to that. My main concern is that you go enough time to know if you have an aggressive tumor that's going to come right back. The last thing you want is to be 5 months pregnant and find out you have a recurrence. And you have to make a very hard decision between saving your own life and saving the baby. So if you let it go a couple of years and everything seems to be stable and fine, then that's a situation where it's usually safe to think about having a baby.
Okay, and what birth defects should these patients be aware of as a possibility?
Well, again, our best information is that chemotherapy, if it's not taken actually during the pregnancy, does not increase the risk of birth defects. So that's kind of surprising information, but very reassuring. All the information that's out there so far says if you wait a reasonable length of time, perhaps 2 years or more, the risk of birth defects, stillborns, miscarriages, all of those things is no higher than the average population.
Is there any chance, Dr. Culp, if you could repeat one answer? Someone's just asking to hear it again, if you don't mind. The question about hypothyroidism, meningiomas, and infertility, if you don't mind.
Hypothyroidism, with or without brain tumors, is a risk factor for infertility. It has a number of effects. As I mentioned, the thyroid is kind of a general thermostat for the whole body. It controls many things, including ovulation and reproduction. So people who have low thyroid function, who are hypothyroid, usually do not ovulate, or if they do ovulate and conceive, there's a higher risk of miscarriage. And that is the case whether or not you've been treated for a brain tumor. Now, treatment of brain tumor with radiation disrupts the regulatory centers in the brain, and one of the most sensitive to be disrupted is the thyroid. So it's a very common problem after treatment of brain cancer. Now, if it's a meningioma that happens to be in a location that is disrupting the pituitary, then there may not have been any radiation, but it may still be disrupting those regulatory centers. If hypothyroidism is diagnosed, whether it's because of a tumor mass effect or whether because of surgical changes or radiation changes, it is very easy to correct with thyroid medication that comes as a small pill. It's taken once a day. It's very well tolerated. So it should be very manageable no matter what the cause of it is.
All right, that looks like all the questions we have. So again, I really appreciate it. I appreciate your time in doing this for our patients and families. Let's pause for a moment and we will conclude our webinar recording.